Here on GameChangers, we're all about helping you stay ahead of pharmacy practice. But why stop at listening? You can earn CE credit for this episode and hundreds more by visiting CEimpact.com and logging into your account or creating a new one. Get credit, get inspired, and make your learning count.
Hey, CEimpact subscribers. Welcome to the GameChangers Clinical Update Podcast. I'm your host, Rachel Maynard. Today, we'll be talking about the management of irritable bowel syndrome with constipation, or IBS-C, specifically in pediatric patients. This is coming up now because the FDA recently approved the first treatment for IBS-C in pediatric patients, which is linaclotide. And this will raise questions about IBS-C more broadly in pediatric patients and where this newer option fits in. So we have a pediatric clinical pharmacy specialist to help answer those questions, and I'm very thrilled to welcome Dr. Christopher Hartley. So welcome, Christopher.
Awesome. Thank you so much for having me. So my name is Christopher Hartley, and I am a pediatric clinical pharmacy specialist at the Johns Hopkins Hospital. I cover the pediatric surgery, gastroenterology, hepatology, and nutrition team here at the Johns Hopkins Hospital. And then I'm a clinical adjunct professor at the University of Rhode Island, as well as a part-time assistant professor of the Department of Surgery here at the Johns Hopkins School of Medicine. Thanks so much for having me today.
Yeah, we're very excited to have you. And I know, given your expertise here, it sounds like you're a great fit to speak about this option and where it might fit in for managing IBS-C in pediatric patients. So I think this is a question that tends to come up just because constipation can be common in children and it's often maybe difficult to manage. And so thinking about what options are available and helping sort through all that is going to be really helpful, I think. So very excited to have you and thank you for your time. But let's start with just an overview of what IBS-C is and how it differs from other forms of constipation.
Yeah, sure thing. So IBS, the first thing I think that we should think about is looking at our NASP again, the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition. They first define as looking at organic causes of disease versus functional causes of disease. So your organic causes of disease are going to be things that are proven or have a physical cause. So that would be like structural damage, inflammation, biochemical abnormalities. So this is going to be things such as your GERD, ulcers, your Crohn's disease, or your ulcerative colitis, celiac disease, or colon cancer. And then there's going to be your functional diseases. And so functional diseases are different in the fact that they have a structurally normal anatomy that doesn't function well.
Mm-hmm. Okay.
And so for these patients, the biggest thing is going to be that generally for parents, there's going to be a lot of questions. There's going to be a lot of tests, and those tests are generally going to be inconclusive. And so, they might get an X-ray, they might get a CT scan that won't show anything, but functionally they're having a lot of issues. And so that's where our, IBS and would come in compared to our IBD or irritable bowel disease like ulcerative colitis or Crohn's, where they would actually have structural abnormalities along their cells and inflammation.
Right. Okay. So that's a good clarification. So inflammatory bowel disease is an example of more of that physical sort of cause, whereas this organic etiology could be hard to pinpoint, really hard to define what exactly might be leading to IBS-C then is what you're saying.
Yeah, exactly. And so it's a symptom based, right? It's a diagnosis of exclusion almost. And so historically, as early as the 1950s, this was first described by John Apley as having episodes of abdominal pain severe enough to affect activities with greater than 3 months. And so these patients are going to have abdominal pain, which is somewhat where it's differing from functional constipation. But they're not going to actually have, if you went under for like a colonoscopy, they wouldn't actually show those signs of disease.
Okay, so you mentioned the constipation and the abdominal pain, and you highlighted a little bit about that frequency, but could you tell us a little bit more about that and what is considered IBS-C versus just sporadic constipation and possibly abdominal pain to go along with that?
Yeah, sure thing. So for the abdominal pain aspect, so essentially for IBS-C, there's two different thoughts of how it occurs. So there's a top-down approach, which is where the it's a brain-gut connection for a lot of functional diseases is how it's described. And so that brain-gut connection, the top-down approach would be that the brain is sending impulses to your peripheral organs on a brain-gut axis that generally creates alterations in your body that causes either that constipation or that diarrhea. And then there's
Okay.
also a bottom-up approach, which would be that peripheral factors in the gut are leading to changes in your cerebral function that causes some of this.
Hmm.
And so a lot of the time, the kind of big challenge is figuring out what exactly does this patient have.
Right.
And so there's a lot of different things. And so the Rome criteria, which is the big non-for-profit organization that does a lot of these diagnosis of functional brain-gut connection, has a couple of different subcategories for different types of bowel disorders. So,
Okay.
for example, you have your IBS-C, and so IBS can be further subdivided. IBS can be primarily constipation based, primarily diarrhea based, or a mixed picture. And so that has to
Hmm.
do with the abdominal pain that occurs from this disease, plus the Bristol stool scale, which is a scale of 1 through 7 for how hard or how soft your bowel movements are.
Okay.
And so 1 would be similar to like acorn. 3 is like kind of sausage, kind of around where you want to be is a 3 to 4. And then 7 would be liquid diarrhea.
Okay.
And so for patients, if you have the majority of your stool being that 1 and 2 on the Bristol scale, that would be a
Okay.
IBS-C or constipation. Whereas for the diarrhea, it would be more towards a Bristol of 6 or 7.
Okay.
And so the IBS is one of the subcategories. Then there's functional constipation below that. Functional constipation would be that you could still have these Bristol stools of 1 to 2, but the big difference is that they don't actually experience pain with it.
Okay.
So
Okay.
when we get into some of the studies for this medication, they do study both functional constipation and IBS-C at the same time, which is somewhat
Mm-hmm.
interesting.
Mm-hmm.
And then
Mm-hmm.
other ones that are similar kind of brain gut disorders are going to be opioid-induced constipation, technically falls under Rome criteria now, functional defecation disorders, and then functional abdominal bloating or distension.
Okay. Okay. So that's a good differentiator. So thinking about IBS-C specifically, it can be this mixed picture, as you said, or um, primarily with constipation or diarrhea. And thinking about the abdominal pain that goes along with either the constipation or diarrhea, that's a key differentiator, it sounds like.
Yep.
And in terms of frequency, how often are patients with IBS-C considered, how often can we expect them to be reporting abdominal pain in addition to that constipation?
Yeah. So generally they would be having it's usually less than 3 abdominal movements per week over a three
Bowel
month
movements.
period. Yep, bowel
Bowel
movements. Yeah.
movements. Okay.
Yep.
Yep.
And so
Okay.
generally the pain is associated when you are having that bowel movement as well.
Okay. Okay. Got it.
And
Got it. Okay.
it should clear with that bowel movement.
Okay. And so in terms of pediatric patients specifically, because that's sort of what's new in why we were talking about this is because this
Yeah.
linaclotide is now approved for pediatric patients. Do they present any differently than adults? Or can you talk a little bit about how common IBS-C is in pediatric patients? How often do we see this?
Sure, yeah. So generally speaking, for like pediatric gastroenterologists, this is one of the most common reasons why these patients would present to
Mm,
clinic.
okay.
So IBS-C specifically, IBS-C is
Okay.
much more common in children, whereas for
Okay.
adults, you have more IBS mixed picture or IBS
Okay.
diarrhea. And so that's
Interesting.
kind of where the big differentiation is.
Interesting. Okay, so it's not uncommon, and it I guess if you had a patient presenting to you, regardless of your practice setting, and the patient was complaining of constipation with abdominal pain, what sort of next steps would you said it's a clinical diagnosis rather than necessarily something or a diagnosis of exclusion. And so what are sort of the next steps if you have somebody presenting with these symptoms? What kinds of questions would you want to ask?
Yeah, sure. So a lot of the questions that you're going to be asking these patients First off, you're going to want to make sure that you're ruling out things such as, an IBD picture, so Crohn's or ulcerative
Mm-hmm.
colitis. So
Mm-hmm.
in order to do that, you generally, these patients, when they come in with abdominal pain, depending on the age that you're looking at, you might be having to rule out things like appendicitis. So they might be getting
Mm.
an X-ray to look to see if their appendix is inflamed. Because if that's the case, then you can, go in and do an appendectomy. And then if they are quite backed up, so if they need like a pharmacologic disimpaction,
Mm.
so using something like polyethylene glycol to clean the patient out. Generally, that's part of the story as well. And then also getting a good med history on the patient. And
Mm-hmm.
so
Mm-hmm.
for these patients, if you have long-term constipation, what can actually happen is you can actually have a fecal ball form in the rectal vault. And so if that happens, because in your large intestine, the primary thing that's happening is you're pulling a lot of your water out of your stool
Mm-hmm.
to
Mm-hmm.
reabsorb it. And so the stool itself can actually calcify. And
Hmm.
if the stool is calcified enough, that would be where you might need a manual disimpaction in order to
Okay.
clean that out. But you want to make sure also these patients could, in their description, tell you that they are having some stool that's wet stool that they're not able to hold in, which would be called encoparesis. And so that's actually where the liquid stool is going around the outside of that calcified
Okay.
stool ball and coming out. And so that
Okay.
could ruin clothing for them and make it harder for them because they wouldn't be able to control that.
Okay. Got it. Okay. Yeah, interesting considerations there to be listening for. And as you say, to also take that med history, find out how long this has been going on, think about medications that might be contributing to constipation more broadly. And I think also, thinking about red flag symptoms like
Yeah.
bleeding, weight loss,
Yeah.
that sort of thing. But yeah, in terms of the management of IBS-C, if you have somebody who is diagnosed, what are the standard in pediatrics
Yeah.
specifically we'll focus on, but what are the standard treatment options for this?
Yeah, so your most common treatment options, none of it was actually studied in pediatrics, interestingly. But generally speaking, it's your high dose stimulant laxatives. So
Mm,
that's going to be like your senocides and your bisacodyl.
mm-hmm,
And so this is going to help with kind of that intestinal smooth muscle
mm-hmm,
squeezing, right? Your
mm-hmm.
push to try to squeeze out the stool, as well as using like your polyethylene glycol, so your osmotic agents.
Okay,
Those are kind of your mainstays of therapy. You're going to be giving high doses, and you're going to
okay.
be trying to get them to have that come out. You could use stool softener, so that would be like your docusate, but doesn't help as much as your high dose stimulant laxatives. And then with the pain aspect, this is where you use like your antispasmodics. So things like dicyclomine and hyoscyamine are your two most common,
Mm,
and those are
mm-hmm,
going to be blocking acetylcholine.
mm-hmm, mm-hmm. And what about in children specifically? And knowing that this is a chronic condition and uh, these medications may need to be used longer term, what are the considerations around that? What kinds of discussions do you have with parents around safety considerations?
Yeah, definitely. And so in that area as well, you also want to make sure that you're trying to think of, what's the long-term aspects for this
Right,
and what kind of
right.
other things can you do that are besides medications, right? Medications work great, but this is going to be things like guided meditation, yoga therapy, and then if they have specifically defecation issues, you can actually go to pelvic floor therapy for this. So
Mm,
primarily floor therapy, you're thinking of patients after giving birth. But there
hmm.
are physical therapists that actually do pelvic floor therapy for patients that help when they have IBS, which is kind
Hmm.
of interesting to
Interesting.
help with making
Yeah.
sure. And I think that that's kind of also where some of the things like squatty potty come into play.
Uh-huh. Uh-huh.
And so making sure that you have a good setup when you're actually using the bathroom to make sure that you're
Right.
on there, but also making sure that you're going frequently. So the general recommendation is that after you eat your food, you should go to the bathroom about 30 minutes later, and you should spend mo no more than 10 to 15 minutes on the toilet itself.
Mm-hmm. Okay.
And then there is some controversial opinions on diet. So this would be like your FODMAP elimination diet. And
Hmm.
so this is FODMAP is fermentable oligosaccharide, disaccharides, monosaccharides, and polyols or short chain sugars that can lead to cramping, diarrhea, constipation, stomach bloating, gas, and flatulence. So these foods, it's generally, if they're going to do this, they would do it for 2 to 6 weeks to see if it has any benefit, but not long term. And so this would be things like dairy-based milk, yogurt, ice cream, wheat-based products, beans and lentils, artichokes, asparagus, onions, apples, cherries, pears, and peaches. So kind of all your things that you think of um, that are really tasty, in my opinion. You kind of
Hmm.
get rid of those, and then you see if that helps. It's controversial because it's a lot of things out of your diet,
Right,
and a
right,
lot of those
right,
things are kid things that especially a kid would really enjoy, right?
right,
You know,
right,
you're
right.
kind of
And that
taking out a
have
lot of their
nutrition.
good
Yeah, you're
options.
trying to provide
Yeah.
nutrition too. They're growing. So yeah, that's a challenge.
Yeah. And so that's one of the biggest things I think that's challenging is that you have to figure out, how much buy-in can you get and how much of this kind of cognitive behavioral therapy aspect can you
Right,
do while you're also giving these medications to hopefully set this kid up for success.
right,
Um,
right. Yeah. And just like with most things in pharmacy, the non-drug measures are almost as important, if not more important than the drug measures. But it is good to know that there are options to try, both non-pharmacologic and pharmacologic. And I think you highlighted a few of those treatment options that are sort of current standard of care. And so if we think about, you alluded to the fact that a lot of the data we have for these treatments are based on adult treatment success. And so when we think about this recently approved linaclotide for IBS-C and pediatrics, what kind of data do we have to support the use of this option? Because it made a little bit of a buzz. And how does it fit in when we think about those other options you described?
sure, yeah. So one of the things that I think is always, interesting is we have, FDA approvals, and then we have a lot of these smaller kind of case studies. And so in pediatric literature, a lot of the times you really don't get a great um, clinical trial that's happening, right?
Right, right.
Whereas for adults, you could get, several thousand patients. For
Mm-hmm.
pediatrics, usually it starts out with a smaller group that's trying something and they present a case report somewhere or
Mm-hmm.
a case series, or they have a poster at one of the,
Mm-hmm.
conferences, and then kind of everybody tries it out from there. So it's not infrequent that we have these, adult studies where you have
Mm-hmm.
this a big adult study, and then you have this much smaller pediatric, study that might be single center. Maybe you have a couple of colleagues at other institutions that are also interested in this and want to try it out. And they're also, trying to see. I think, in pediatric studies, it's always challenging because, they're a vulnerable population. And so when
Mm-hmm.
you're looking at your IRB for these
Mm-hmm.
patients, um, for patients that are pediatrics, older adults, incarcerated individuals, those patients are always going to be harder because they can't advocate for themselves the same way. And so a lot more of that, safety information has to be done before
Mm-hmm.
they're able to actually try a clinical trial. But
Mm-hmm.
linaclotide is kind of cool because they actually have some pediatric data, which is great. The other medication, just before we talk about that, that was previously on the market before linaclotide was lubiprostone.
Mm-hmm.
And so this was a medication that was had some randomized control trial in pediatrics. Um, and it's similar to linaclotide in that it's a it's a secreting medication. And so
Mm-hmm.
with that, what it's doing is it's pulling intracellularly into the GI tract to help with those bowel movements. This medication actually ended up not being used that often because in some of the pediatric randomized controlled trials, it actually had no statistical significance for spontaneous bowel movements when compared to placebo.
Okay. Okay.
So then linaclotide comes onto the market.
Yep.
And so it's a guanylate cyclase C receptor agonist. So what it's doing is it's increasing intestinal fluid secretion, accelerating intestinal transit, and decreasing visceral pain. And so the first study for this was a phase 2 clinical trial, and it was done by Carlo Di Lorenzo and colleagues. And this one, it's on clinicaltrials.gov, which is a great place to look for a lot of these studies,
Mm-hmm.
especially if they don't
Mm-hmm.
actually have the, paper out yet. And so
Mm-hmm.
this was a phase 2 clinical trial that was safety and efficacy of linaclotide in children 7 to 17 with IBS-C. So this was a safety and an efficacy study. It was 4 weeks, randomized, double-blind, placebo-controlled, parallel groups. And this one was kind of interesting because it was a dose-ranging trial. So normally, if
Okay.
you're thinking about your, clinical trials overall, generally your phase 1 clinical trial is going to be where you're trying to figure out, the dosing. Phase 2 is where you're figuring out the safety of it and some of the efficacy. Phase 3 is kind of your big trial where you're looking at efficacy, and then you get your post-marketing data.
Mm-hmm.
And
Mm-hmm.
so this one was interesting in the fact that it does dose ranging. So they took patients and they figured out their dose. They had 3 different categories in all of their doses. And so they had one group that was 18 to 35 kilograms. They had one, and then they had greater than 35 kilograms. And so within those, they would give a fourth of the dose, a half of the dose, or what they wanted to do as like their actual dose
Okay.
to
Yep.
see if there was any difference in abdominal pain or side effects.
Okay.
And so this one, the primary endpoint was change in baseline during a 4 week period in spontaneous bowel movements. And spontaneous bowel movement is described in all these studies as the having a bowel movement where you didn't have a laxative or a suppository or an enema that
Okay.
day or the day before.
Okay.
And so for this study, it's kind of interesting. So for the actual FDA approval now, looking, a couple of years later, the
Mm-hmm.
dose is 145 micrograms once daily. But in
Okay.
this, for patients that were 18 to 35 kilos, they started as low as 18 micrograms, so a much lower dose, and
Mm.
they went as high as 72 micrograms. And then if they
Okay.
were greater than or equal to 35 kilos, then they got anywhere from 36 micrograms to 145 micrograms. So actually
Okay.
getting up to that dose that you're going to do for your
Mm-hmm.
approval.
Mm-hmm.
Their secondary endpoints was change in bowel function, a change from baseline in abdominal pain. And so they did 1 through 4. And then the big part of it was their safety endpoints. And so they had 101 randomized patients that all tolerated the treatment well. They had treatment emergent adverse effects, which means that they had an adverse effect that they could specifically tie to the medication that was not there prior to the medication. And upon discontinuation, the side effect resolved. That occurred in 27 patients, so around a fourth of the patients. 2 of
Okay.
them led to treatment discontinuation, so abdominal pain or diarrhea, and the most common side effects were diarrhea and abdominal pain. All the diarrhea in the study was considered mild, and none of it was severe, which is pretty similar to the adult data.
Mm-hmm. Mm-hmm.
And so
So
this
I'll let
was
go. Yeah.
pretty good. Yeah, I mean, pretty good. It's similar to the adult data. It's lower doses overall than you would see in a lot of these patients when you're starting with IBS-C. So IBS-C, the starting dose for patients 7 and up now is 145 micrograms,
Mm-hmm. Mm-hmm.
whereas functional constipation, your starting dose is 72 micrograms.
Okay. Okay. And just to clarify, this drug
Yeah.
was originally approved for, previously approved for IBS-C in adults, chronic idiopathic constipation in adults, and functional constipation in pediatric patients 6 and older. And now this new indication adds on to the IBS-C in adult indication, expanding it to the 7+ population.
Yep, correct.
Yep. Okay. And so, but what it sounds like is bottom line is there is still more limited data, which, as you said, is sort of the nature of pediatric population data generally.
Yeah.
And there's some, but we do have some data here from this dose ranging study, and I guess what's the bottom line from that what you just described and what the approval is,
Yeah.
and where is its place in therapy for IBS-C in pediatric patients?
Yeah, sure. So actually before that, there was a phase 3 clinical trial after from DiCarlo and colleagues. And so that's going to be the one in the Lancet Gastroenterology Hepatology from 2024, which is where that functional constipation approval comes from. And then they're at Digestive Diseases Week, or DDW, which is a big
Hmm.
conference, is where a lot of the data, especially like the kind of new stuff that hasn't actually been published yet, is where a lot of your data comes from for the IBS-C patients. So more long-term studies. The one that was presented this past year at Digestive Diseases Week was a 52-week study, which is kind of interesting. Patients had to
Okay, yeah,
be
much better than 4 weeks.
yeah, and so that's the
Yeah,
other challenge with a lot of these studies.
right.
It's, where does it work in treatment? So this was the Digestive Diseases Week was 52 weeks, age 7 to 17. Patients had to be 18 kilos or greater, which is pretty great. And it was patients from that phase 3 clinical trial with the functional constipation. They were either on 290 micrograms, which is the adult dose, 145 micrograms, or placebo from the previous trial, and then they were allowed to
Okay.
continue as an open label, which is interesting.
Okay.
And these
Yeah.
patients still had diarrhea and abdominal pain. 6.1% of them had that diarrhea, still mild. None of them were severe. And so the place in therapy is kind of nice because it's if you have a pediatric patient who is greater than 7 years old and they, or, greater than that 18 kilos, if they're 6 years old and 10
Mm-hmm.
months and they weigh, 20 kilos, you could probably still get away with doing it.
Mm-hmm.
Um,
Mm-hmm. Mm-hmm.
I think the biggest barrier there will be insurance that we'll talk about in a little bit. But the place in therapy right now is if you have a patient who you've, tried meditation therapy, you've tried cognitive behavioral therapy, you have been doing your gold standard, so that high dose stimulant laxative plus your polyethylene glycol, and you're still not having, full resolution of symptoms, they're still having that constipation and that abdominal pain. I think it's a great place to try. If you Usually I would start at, that 145 micrograms, but it's very provider dependent. And so
Mm-hmm.
that's kind of the interesting thing. So I would say, overall in IBS-C, there's, a lot of information, but not a ton of information. And so some providers might start them at 72 micrograms, which is lower dose, more of a functional constipation picture. Whereas, and then you could always titrate up, and some of them might start at 145 micrograms once daily. But I think it's a great
Mm-hmm.
thing to try.
Mm-hmm.
Um, if you're thinking through like those big side effects, so diarrhea and abdominal pain, some people will have that diarrhea pretty significantly. It's considered mild in the study, but I feel like when patients are having that, especially if it's causing issues at school,
Right.
that might be enough to scare them to, say, I don't want to try that again.
Right.
Um, the diarrhea does go away after about a week or so,
Okay.
which is good. And so one of the big points that I like to, talk about is try it on a weekend, try it on a long weekend maybe,
Mm-hmm. Yeah,
just to
great
make
point.
sure. Um,
Mm-hmm.
but I think that it's definitely worth a try, especially, I mean, some of these early studies, the safety and efficacy study was a 4-week trial.
Mm-hmm.
So you could
Mm-hmm.
always try it, and if it's not
Mm-hmm.
helping you out, you could always, get rid of it. And I think that that's an important aspect of our job as pharmacists is, helping with that prescribing information, but also helping with deprescribing if we need to, and if we're not seeing a
Right.
benefit.
And to that point, would a patient be adding this to those laxative and potentially antispasmodic options as well, or is this a replacement?
Yeah. So, according to the like NASPGHAN group, which is the North American Society, their committee guidelines were should be considered as adjunct to high dose stimulant laxatives when
Okay.
treating refractory
Okay.
constipation with poor response to optimize high dose stimulant laxatives or when high dose stimulant laxatives are not tolerated. So this would
Okay.
be in addition to.
Okay, got it. Or if not tolerated, but yes.
Yeah.
Okay, so that's good clarification. So you may see patients continuing on their laxative that they've been on and adding this to provide additional relief. And how long would you wait for to see the effect of those non-pharmacologic and pharmacologic measures that we talked about before thinking about adding this in terms of pros, cons, and place in therapy broadly? What would make you think, okay, it's been long enough that we should consider adding something else?
Yeah, I think, the challenge is always also making sure that your diagnosis of exclusion stays a diagnosis
Sure.
of exclusion.
Hmm.
So I would say probably, it wouldn't be happening at your first, outpatient visit meeting the provider. But I would say after, try having a good try of say, I don't know, 3 to 6 months, trying
Hmm.
to see,
Hmm.
does that cause a benefit or is it time that we, switch and try to add something else? I think the other thing that's I feel like I've learned a lot after, finishing residency was that, you want to also make sure that you're not doing everything all at once so you can
Right.
see what's
Right.
actually working.
Hmm.
And so I think, trying out the cognitive behavioral therapy is great. Trying that high dose stimulant laxative, and then if those don't work, not just reaching right away, but maybe giving it, 3 months just to see
Right.
3, 6 months
Right.
maybe to see and make sure.
Right. Which can be frustrating again because it this can affect quality of life
Oh,
and
for sure. Yeah.
yeah. So very can be frustrating to have to spend that long. But as you say, not adding something unnecessarily when you don't even know yet if what you're trying is effective. Yeah, and you mentioned the insurance coverage before. I didn't think that is an important point. You also mentioned the because it is brand
Yeah.
only. And so the cost is a consideration. You also mentioned diarrhea can be a side effect, which of course is sort of the intended effect, but can also be a side effect. And taking it on the weekend is a great little practical tip, I think. What other general counseling points are we wanting to think about if a patient is going to be starting this?
Yeah. So I think, realistically, when they come to clinic that day and you get the prescription for it and you're e-prescribing it wherever it's going to go, um, it's likely going to, if it does go through for insurance, that's awesome. But likely there'll be some sort of prior authorization, I would guess,
Mm-hmm.
or
Mm-hmm.
have to have a peer-to-peer discussion about the patient if there is a denial. So I think that that's something
Mm-hmm.
that I would anticipate. I think another big part is family education, right? And so
Mm-hmm.
really, I think that this is where our providers do a great job sitting down with the family and talking through a functional disorder and how, it's not going to be seen on X-ray. It's not going to be seen on that CT
Mm-hmm.
scan.
Mm-hmm.
Um, you have to kind of think of it more so as migraines, right? And so
Right,
for a
right.
migraine, and usually families do a good job at knowing, I know what a migraine is, where it's not something that you can physically see on an exam, but you know it's there.
Mm-hmm.
And
Mm-hmm.
so a
Yeah,
lot of
that's
the
a good
times our
analogy.
providers like to talk about it similar to migraines.
Mm-hmm.
Um, for counseling points, so it's contraindicated in kids that are less than 2 years old. And that's because of the diarrhea aspect of it. There is a
Mm-hmm.
chance that
Mm-hmm.
you could have severe diarrhea where you would have to get the patient rehydrated. And so
Mm-hmm.
that would be kind of one of your big concerns. Um, it technically has that you should take it in the morning, 30 minutes before breakfast, because if you have a high fat breakfast, you can have loose stools and greater stool frequency.
Mm.
But a lot of these kids, if you're thinking about who's our patient population that we're talking about, these kids aren't having a lot of bowel movements. That's why we're starting
Yeah,
the
yeah.
medication, right?
Yeah,
They've
right, right.
been on an osmotic, they've been on these high dose stimulant laxatives, and, you know, the parents and the patient are, wanting to get through this. They want to have that bowel movement. And so
Mm.
some of our providers will even say, take it at breakfast in the morning to try to have that stool.
Interesting. Okay.
And then another one is going to be if you have difficulty swallowing. And so that's the other big thing to think about in pediatrics.
Mm-hmm.
And so
Mm-hmm.
a 7-year-old might be able to swallow a pill or a capsule. They might not. And if they're not able to, you can open up the capsule and mix it with 5 mLs or 1 teaspoon of applesauce and eat
Okay.
it.
Okay.
Or you can put it into 30 mLs of water. You want to mix it for about 5 minutes. The drug is actually on the beads itself in the capsule.
Okay.
And so the water itself, the drug will disperse into the water, but the beads might still be there. And so it's
Okay.
important you want to drink the whole thing. But if if there's a couple of beads left over in the bottom, the drug has already been given to the patient, and that you don't have to
Sure.
finish every single little
Got
bead in
it.
there.
Okay, that's a good clarification. Yeah. Yep. Okay. Yeah. So again, very practical considerations, especially for this population to be thinking about administration. That is always a consideration. Um, we are about out of time. Any other general takeaways we need to be thinking about with this drug or IBS-C in general with pediatric patients? Unique considerations for us to be remembering as we're chatting with these patients.
Yeah, I think, some of the key, red flags that would be a reason why, if you were talking to a patient, that you should refer them to go talk to their healthcare provider, would be if they have weight loss from this
Mm-hmm.
medication, if they have decreased growth velocity,
Mm-hmm.
if they have blood in the stool, because these could all be signs that they actually have IBS-D, or
Mm-hmm.
IBD, which would be, Crohn's or UC, as well as
Mm-hmm.
if they're having nocturnal symptoms, because that could
Okay.
also be. So if they're waking up in the middle of the night to stool
Okay.
more
Okay.
frequently.
Okay.
But otherwise, I think it's a great medication. I think that, it's a really nice to have another medication to try for these patients.
Yeah, considering the fairly limited options available, you're right. To have an options are good, and again, some of that trial and error can take time, but at least it is an option to be considering in addition to sort of those tried and true methods. And I know you'd mentioned before we started the podcast that you've seen this already in practice in your population. So it's interesting to see how it might shake out once we get more real world use.
Yeah, and there has been times that, if you're submitting for insurance, and they're after a denial, if you're doing a peer-to-peer, there's been multiple times where we've had to submit, posters from different poster
Oh, okay.
presentations and
Okay.
conferences
Yeah.
because that data isn't actually released yet, which is interesting. So actually in the
Yeah.
package insert for linaclotide, the data that they have for their trial actually isn't in any publication yet. My
Okay.
guess is that it's going to be coming in the near future, but it's the study that they're using for that package insert is actually in the functional constipation phase 3 clinical trials supplementary appendix. So
Okay.
I'm
Okay.
guessing that the paper is coming soon,
Hmm.
but they just haven't actually had that paper yet. So sometimes it
Got it.
is unpublished data. So trying to figure out your best bet of, where does the data live? And that's where staying with different organizations, those professional organizations can be extremely helpful. And
Hmm.
working with other colleagues to see, have you seen this before? And if you have, is there any areas that we can, try to see if that information is out there? And do you have
Yeah.
information on it that I could submit for this patient to try to
Yeah.
do best for the patient?
Yeah. Yeah. That's interesting. And again, a very unique consideration with pediatric population in general and some of those considerations there. But thank you so much, Christopher, for sort of enlightening us on IBS-C in general, how it compares to the other forms of constipation, thinking about the treatment options we have and where linaclotide might fit in, knowing that treatment still needs to be individualized. But I really appreciate your point too about supporting those families and ensuring that the family is on board and working through some of the options available. So thank you so much. And to wrap up our discussion, this is the Game Changers podcast. So we always wrap up with what do you think is the game changer that you want our listeners to walk away with about this topic?
Yeah, I think the game changer is, you have a patient who is, you know, refractory to the current management that they have for IBS-C, and now you have a medication that you can try that's a cyclic guanylate cyclase agonist that could hopefully help them have more spontaneous bowel movements, have, less abdominal pain, and they might have some abdominal distension and a little bit of bloating and diarrhea, but overall it seems safe and effective. So I think that that's really the game changer for it.
All right, that we have a new option. And again, as you say, with generally limited data in this population, so good to have another option available. Excellent. Well, Christopher, thank you so much for your time. We really appreciate it. And just look forward to having you again on this podcast. It's been a great sort of enlightening considerations with this population, I think, for me anyway. And so glad to have your expertise here.
Yeah, thank you so much. It was great. I enjoyed it.
Excellent. Excellent. Well, listeners, we talked about a lot of very great practical tips today, and these will all be summarized in the practice resource that goes along with this podcast and is included in the CE subscription. And be sure to claim your CE credit for this episode of Game Changers by logging in at CEimpact.com. And as always, have a great week and keep learning. I can't wait to dig into another game-changing topic with you all next week.